dear Claire, dear Jean-Jacques, dear colleagues. As Professor Quillagion has just shown you, he's established the relevance, clinical relevance of cytopenias in our patients and the need to address this therapeutically. So in the following minutes, I would like to summarize some of the therapeutic options and also results from clinical trials in that regard. And to begin with, I would like to spend some time on this slide to summarize the current therapeutic approaches and options we have in order to treat patients despite their cytopenias. So the management of these cytopenic MF patients requires a balancing of the cytopenia support on one side, but also at the same time delivering disease-directed therapy. And if we look to the left here, supportive care is crucial, especially with transfusions, red cell and platelet transfusions in patients with severe cytopenias. This is truly life-saving treatment, but it's also a possibility to overcome transiently cytopenia. On the other hand, we have erythropoiesis-stimulating agents. There are androgens like danazol, we'll talk about this in a minute, that we can use, and also IMiDs. On the right, we see that more targeted therapies can also address cytopenias, and we've put up somewhat a controversial term of disease-modifying drugs for anemia-directed JAK inhibitors, such as momelotinib, or cytopenia-directed and compatible agents, pacritinib and momelotinib. So we may want to discuss what we mean by disease modification, and is it really disease-modifying therapy. In addition, we have anemia-directed therapy, for example, luspatercept and others, acting as TGF-beta ligand traps. TGF-beta suppresses erythropoiesis, so if we inhibit TGF-beta effects or BMP effects, activin effects, then this may allow erythropoiesis to occur and anemia allowed to be treated. And then, of course, we have a wealth of investigational agents and combinations of therapies, and you can see some examples here. DISC-974, pelabresib, and the calreticulin mutant-specific antibody, INCA-989. Actually, there are 2 targeted therapies approved for patients with cytopenic MF. You can see that on the bottom. So momelotinib is approved in the US and Europe for adult patients with MF and anemia. And pacritinib is not approved in Europe, but is approved in the US for patients with MF with a platelet count of less than 50. And that might be relevant later on for the discussion of the questions. So let me review the clinical data, starting off with momelotinib and looking at spleen responses, symptom responses, but also transfusion outcomes. And in these 3 phase 3 trials, we saw that momelotinib maintained or improved spleen and symptom responses while improving transfusion outcomes. So on the left, you see this first-line trial, Simplify-1, second-line trial, Simplify-2, and the Momentum trial addressing specifically the needs of patients with MF and anemia. And as you can see, in addition to spleen and symptom responses, in bold, you can see the transfusion independence responses going from 30% to 67% here in the Simplify-1 trial. And these were consistently improved over ruxolitinib, BAT treatment, and danazol. On the right, you can see that in longitudinal assessment, 77 to 87% of patients maintained or improved transfusion intensity versus baseline across these 3 phase 3 trials. And you can see here improved transfusion intensity, so the red blood cell transfusion burden was improved by momelotinib more than the comparators. There was also an impact on hemoglobin levels, and I think we nicely see that after crossover in these trials, the comparator patients that then received momelotinib had an increase in hemoglobin, which was seen initially already with momelotinib treatment, and this was true in these 3 trials. So across these trials, hemoglobin levels were maintained with momelotinib, better maintained compared with the comparators. And in a post-hoc analysis of patients with baseline hemoglobin levels of less than 10, this is actually what we refer to as moderate or severe anemia, achieving a hemoglobin of at least 10 grams per deciliter at week 24 was associated with a numerically longer overall survival, even though that was not significant. But this stirs up discussions of when we should begin to treat these patients. These outcomes were also present in patients with thrombocytopenia. You can see the platelet levels here, smaller than 150, 150. These hemoglobin responses and anemia responses were also seen in thrombocytopenic patients. But of course, as you can see, the number of these patients in these trials were quite small. But they still suggest that momelotinib activity may extend beyond anemia and also can be addressed in thrombocytopenic patients. This is important because quite often patients may have anemia and thrombocytopenia. If we move to pacritinib, there are similar results here. You can see that pacritinib improved clinical outcome in MF patients with thrombocytopenia, and we can look at spleen volume response and symptom response on the left, but also there was a sub-analysis of transfusion independence, which showed that there's a benefit of pacritinib also on transfusion independence in these patients. Moving to luspatercept as a TGF-beta and activin BMP inhibitor, this improved anemia outcomes in MF, both in the setting of monotherapy, but also in the combination group with ruxolitinib. These are data from a phase 2 trial, and both, if you look at mean hemoglobin increase, but also reduction in RBC transfusion burden, this was evident, and there's a currently ongoing phase 2 study combining momelotinib with luspatercept, also showing some stabilization and reduced transfusion burden results in the early analysis. Then I would like to briefly touch upon the BET inhibitor pelabresib, which was assessed in the MANIFEST-2 trial, phase 3 trial, which tested the combination of pelabresib with Rux versus Rux alone. And as you can see here, there was this significant superiority in terms of spleen volume response. TSS 50 was also numerically increased, and there was a sign of combined improvement of combined spleen and symptom response. And also, as you can see here, there was a positive signal on hemoglobin response, both being hemoglobin improvement and also decrease of anemia, and that came with a certain signal for thrombocytopenia, but at a fairly low level here in patients. Finally, selinexor is an export inhibitor, which also was tested or is being tested in a current trial. in the combination with ruxolitinib versus Rux alone. And here I'm showing initial top-line results from a press release, so we're still waiting for the formal presentation of these data, showing very interesting spleen responses, and it will be very interesting to see whether we can also see anemia or thrombocytopenia responses in the long run. At the moment, there was no difference, significant difference between the two arms in terms of adverse events. And then there's a lot of interest by these emerging potential therapies that are in clinical trials, and I've just listed the ones that I've already mentioned. I'd like to mention KIR50 or aretrocept as a TGF-beta ligand trap. There's data on a BMP inhibitor, HJV inhibitors, but also, very importantly, the phase 1 trial with the mutant CALR inhibitor Inca 989 shows some first beneficial results on not only the disease, spleen and symptoms, but also improvement of hemoglobin. So, as key takeaways, I would like to summarize that data from the phase 3 Simplify and Momentum trials indicate that momelotinib can increase the rates of transfusion independence in patients with MF and anemia, while also contributing to reductions in spleen size. And this may be considered as an alternative for patients with platelets of at least 25,000. So this is important in Europe because we cannot give pacritinib. Results of the PERSIST trial suggest that pacritinib is effective in patients with MF and severe thrombocytopenia, and as I've shown you, can also improve rates of transfusion independence. I've shown you some data from the phase 2 trial with luspatercept, both alone or in combination with ruxolitinib, which can address anemia and improve anemia in our patients. And the independence trial is currently ongoing. Did not meet its primary endpoint very narrowly, but may still be an interesting concept to combine luspatercept and TKIs. And then several emerging therapies with novel mechanisms of actions are being investigated, especially therapies that are addressing the specific oncogenes.